Hi colleagues, this video has been produced to give you some information about our new clinical model. We're all too aware that the clinical model we work to at the moment, including the time-based response standards, has its origins in the 1970s. We know a lot's changed in our profession since the 1970s. We shouldn't lose everything from the past. We should continue to be a caring, patient-centred organisation that treats every patient with dignity and respect and does the best for everybody that we can do. However, we know that the clinical capabilities of the service have moved on since 1974, and we need to recognise that in our new clinical model. We've spent £7.5 million in the last 3 years on new equipment and new vehicles, and we need to maximise the benefit of that for our patients. Now, you all know that one of our problems at the moment is far too many of our emergency calls are categorised as red A8 emergencies. Some days it's 4 in 10 of our emergency calls, so you all know what this means in practice. Far too many red calls leads to rapid response cars being sent in one direction, then stood down and sent in another. It leads to ambulance crews being sent far away out of their home area to deal with red calls because there's no other resource. We all know that quite often when we arrive at a case, the patient has a problem, but it's not immediately life-threatening, and the patient hasn't benefited at all from an 8-minute response. So what are we doing? Well, we've listened and we've looked at the clinical evidence, and what we're proposing is a new model where the only calls that will be categorised as red and will therefore get an 8-minute response are cases where somebody's not breathing, somebody's choking, somebody's bleeding to death, somebody's unconscious, or somebody has a truly life-threatening problem. This will reduce the number of red calls we receive as a service every day from around 500 every 24 hours down to about 150. What this should mean is when you're dispatched on an A8 red emergency, there really will be a patient who's counting on you to provide life-saving care and assessment on your arrival as quickly as possible. We're reintroducing the amber category for less serious emergencies. Within this category will be some stroke calls, chest pain calls without life-threatening symptoms, people who've got a fractured neck or femur, and most accident patients. Now, increasingly, these patients will receive secondary triage before you are dispatched. Our nurses and paramedics working on our secondary triage desk at Vantage Point House are looking at calls from across Wales and providing secondary triage, and this should mean that once you're dispatched on an amber call, there's less chance of you being stood down en route. We know, don't we, that for patients having a heart attack or patients having a stroke, what's important is not the speed of our response. What's important is the assessment that you do when you arrive to find the patients having STEMI, to find the fast positive patients, and then to convey them to a PCI centre or a hospital with a CT scanner that does stroke thrombolysis. This is what makes a difference to patients' outcomes, not how quickly we arrived. You will have encountered many patients that we've taken 9 or 10 minutes to get to. You've assessed them and you've taken them to the heart attack centre, or you've taken them for stroke thrombolysis, and they've gone on to lead a fully functional recovery. That is what our new clinical model is designed to achieve. It's designed to free your time up to respond immediately to the life-threatening emergencies. It's designed to allow us some time to do better triage before you're dispatched, to make sure that when you are dispatched, you know what you're going to and you're able to provide the best service for patients. Now, there will continue to be a green category, and the green category will be for patients that have been referred to us by a healthcare professional. These are called Card 35 calls, as I'm sure you're aware. The Card 35 calls are going to be segregated from the 999 calls and are going to be managed by a different desk within the control centre. This means, doesn't it, that our urgent care colleagues will be maximised in looking after this group of patients, for which they have absolutely the right skills to make sure these patients are safely and professionally taken to hospital. It'll also mean that when you attend to a patient and you refer the patient back for Card 35 transport, increasingly the timescale that you set should be met. We're not going to get this right overnight, and there'll be some teething troubles along the way. We want to hear what you've got to say. You need to speak to your staff side representative, your clinical team leader, your local management team, but actually when the senior clinical team and the medical director visit your locality to discuss this model in more detail, it's really crucial that you turn up and have your say. This model is based on clinical evidence and our experience as an organisation, but we want to hear what you've got to say.